Hey class, good morning or good afternoon, whatever time you're watching this, to pharmacy residents or pharmacists that may be watching this. We're going to do a brief discussion on immune biologics. I don't know if this is, it's not a wheelhouse of mine. I'm not going to sit here and act like I'm an expert in this. So when I give this lecture, it's kind of like we're learning together and I have to rehash it out. But we'll talk about immunosuppressants and vaccinations is pretty much what we're looking at. Now, let's just jump into the slide deck. And this would be week 6, lecture 2, week 6, lecture 2. So let me go to my screen share, and there it is right there. Minimize that. Let's see if I can. I think we need video there. That gets rid of that. When you turn off the stop video, I think it makes that screen up top go away. So anyway, as we jump into this discussion, I'm not going to get in a detailed discussion about the immune system, but I think as future providers and practitioners, you need to have an appreciation of the immune system and how the immune system works. Some things you need to know. You need to understand the complement system. I think that's probably the first place to start at and go with. If you don't understand it, and there's a lot of this stuff, Dr. Google, just Google it. But we talk about the complement system. So the immune complement system, it's a complex set of proteins, and they're in the blood. And in essence, they work together to identify and eliminate foreign invaders. Those are going to be those antigens in essence. But gosh, it can be bacteria, viruses, microorganisms from, you name it, you name it. But the reason they call it the complement, just like it says, it's a complement because it complements, or the best way to put it is enhances the ability of antibodies and phagocytic cells to clear those pathogens from the body. And there's multiple antibodies. There's immune globulins. There's a lot that goes into this. That's why I can't. I wish we could spend a lecture on immunology, but I'm hoping you get this from your other courses. But many proteins, 20, 30, 40 proteins in the complement system, and there's different complements that you all are going to order to see if a patient's deficient in complements, especially if they have ongoing infections or there's issues going on. But they circulate in an inactive form in the bloodstream, and at some point they're activated, and it's going to be by an antigen, or AKA a foreign substance, right? And we just think bacteria for this discussion, but it could be viruses. There's a whole list of things it could be. But once these proteins are activated, they can actually directly attack and kill pathogens, and they also can trigger inflammatory responses. And you know what happens when we have inflammation? We've talked about this. That's when you get recruitment of white blood cells. You have those chemotactic factors. Gosh, we've talked about them. Tumor necrosis factor alpha, the interleukins, gosh, 1, 2, 3, 4, 6, the list goes on and on, that are chemotactic, and that's when you get macrophages involved. That's when you get the major histocompatibility complex involved. Those are things that you need to know. Antigen presenting cells, that's a term you'll see sometimes. It's abbreviated APC in the literature. But there's two pathways when you think of the complement. There's the classical pathway and there's the alternative pathway. The classical pathway, that's activated when antibodies actually bind. So your IgM, that'd be a classic one. But the classical pathway, that's activated when those antibodies bind to a foreign substance, okay? The alternative pathway can be activated by the presence of pathogen or other activators. I'm not an expert on this, so distinguishing between the two in the body, no. But just know that the immune complement system, that plays a very critical role in protecting the body against infections and, in essence, maintaining homeostasis. I don't want to say it's the director of the orchestra, but it complements it. It's part of the team, and in an orchestra, you have different instruments, but together they make beautiful music. So think of your immune system the same way. And that's when we get into discussions such as B cells and T cells. short-term versus long-term memory. List goes on and on and on. So, okay, let's jump into that. But that's about as detailed as I'm going to get about the immune system. So, uh, I wish I knew more. I wish I could spout off a bunch of stuff, but you will check complement levels though, and in different patients who you just like, you're always infected. What's going on here? Maybe the complement system's not working as it should. The uh, our key terms always do that, but our learning objectives, nothing has changed. And again, when we get into immunity, you need to understand active immunity, innate, passive immunity. You know what immunocompromised mean, but just know that when someone's immunocompromised, having diabetes or a chronic condition can lead to a patient being immunocompromised. So when you hear that term, just don't think of someone on chronic steroids or someone on a chronic calciurin inhibitor for a bone marrow transplant. Many times there's more to it than just that. Um, and just more key terms to go through. So the immune system, again, not going to go into a lot of detail, but you can see there's a lot going on to it. The thymus, we have thymus dependent, thymus independent processes that go on in the body. The lymph nodes are certainly very important. That's where a lot of, that's like a depot, the bus stop where MHCs flag presentations of, hey, look at me, I have a bad guy right here. That's where a lot of that goes on. But the immune system, even we talked about neutrophils and reticulocytes and all the other platelets, all comes from the bone marrow, from progenitor cells. So yes, very, very important. The spleen's important when it comes to infectious diseases. If you've ever heard of the term encapsulated bacteria, these are going to be Haemophilus influenza, Streptococcus pneumonia, and drawing a blank, Neisseria meningitidis. Those three, that's very important. The spleen sequesters so many different degraded products, platelets, red blood cells. There's a lot that goes on, but it also sequesters encapsulated bacteria, those three. So if a patient's going to get a splenectomy, we have protocols in place where we immunize them against Haemophilus influenza B, against Streptococcus pneumonia, against Neisseria meningitidis. So these are all very important things that you need to appreciate. So always, the spleen is your friend. It's, in essence, it protects the body from those infections that are caused by what we call polysaccharide encapsulated bacteria. Now, what are the big three? I'm not going to say it again. Well, I'll say it again so you know it. Pneumococcus, Streptococcus pneumonia, Neisseria meningitidis, and Haemophilus influenza, and we have vaccinations for all three. So, but the spleen does all kinds of stuff. But just a little pearl, do you ever hear of someone getting cancer in their spleen? It's weird that that's the one organ you hear about cancer everywhere, but you don't really. The spleen is one, and it has such a profound function that we just ignore. But anyway, if a patient has a splenectomy, you're going to have to either before or after the fact, if it's traumatic, they're asplenic, whatever it may be, you're going to have to get those vaccines on board. That's very, very important. Okay, we'll leave that at that. So again, I would find a good, even if you Google immunology for dummies, you guys are going to be practitioners, you're going to be prescribing, dealing with a lot of anti-infective stuff. And I think it behooves you to understand the immune system, but you know what it does. And understand that the immune system can be our enemy. Sometimes it sees us as the antigen, and we get rheumatoid type diseases, right? But the immune system, so there you go, recognizes toxins or invading organisms that enter the body as foreign or antigen and produces substances called antibodies. And that's how we fight them. So the protection from the disease, this is what we call our immunity. And you saw active, passive, and innate. Innate is what you're born with. The best example of that is your skin. But the lymphatic system, so this is part of your circulatory system, which includes the bone marrow, the lymph nodes, the spleen, the thymus, and the tonsils. So very important. This plays a role in it. You can see this is all tied together. White blood cells we talked about. These are important because white blood cells, progenitor cells, differentiate into different types of leukocytes, if you will. And we know that bands and which become neutrophils are very important, but or granulocytes, if you want to call it that, but plays a very big role in our immune system. You have your myeloid cell line derived. This is very important. This is your native immunity. So all begins with hematopoietic stem cells. Okay, so this is happening down deep inside. So think of it as your myeloid, and this is your innate immunity, which we'll talk about. We're going to get into the lymphoid cell line, which is acquired. But this is very important in distinguishing between the two. So when you think of innate immunity, let's talk about myeloid cell line derived first. So this all begins with hematopoietic stem cells. And those progenitor cells, they're told what they need to differentiate into being based on the presentation at this point in time. If you need more platelets, you have chemicals that say make more platelets. We have ESA to make more blood cells, as we've discussed. But these are fast acting and they're non-specific. So something to keep in mind. So this is inborn. This is germline encoded. So myeloid cell line derived. This is your native immunity, and it's innate. I always use the skin as an example, though. Your hematopoietic stem cells, the monocytes, very important. Monocytes are where your macrophages and dendritic cells. This is where that cell line comes from. So think monocytes and macrophages, and then just throw dendritic cells. But these are precursor cells. They activate T cells, again, waving a little flag on the major histocompatibility complex to come get me, come get me. But macrophages do a great job of phagocytosis and death, but the dendritic cells, these are going to be the ones that are probably the most efficient when it comes to presentation of an antigen on that major histocompatibility complex. But your macrophage, this is going to cause phagocytosis and then cytokine release. This is very important. This is where you get the induction of inflammation. Remember, inflammation is not a bad thing at times. It's a good thing. It can be a survival process, and it's going to be antigen presentation. And then you have your dendritic cells. These are the most efficient antigen presenting cells. But when you think of your monocytes, I want you to think of macrophage activity and dendritic cell activity. And I want you to think of raising a flag saying, I got a bad dude here. I need something to come in and kick its butt. And that's what your T cell is going to do. And that's going to be an active response. Now, B cells come into play because that's going to be your long-term memory of these cells. Okay, your granulocytes, these are very important. These are your neutrophils. These are going to be your eosinophils, and these are going to be your basophils. So you got to differentiate between the three. Eosinophils can be a good friend, but if you have we have some drugs that can cause eosinophilia and eosinophilic pneumonia specifically. A drug called daptomycin comes to mind. Very rare, but I've actually seen it once. And eosinophils in high concentrations are extremely destructive to you and everything else around it, not just the antigen. So it's something you need to be aware of. But in that specific case, what would you do if you had a patient with eosinophilic pneumonia? Well, I can tell you what we did do. We stopped the daptomycin and we gave them steroids and immunosuppressive. But the neutrophil, this is going to be a chemotactic response due to inflammation. You're going to have the phagocytosis and killing. You're going to get free radicals due to oxygen. You're going to get degranulation, and these granules are what kill microbes. You'll hear the term left shift. And what a left shift means is there's an increase in immature neutrophil precursors. These are what you call your bands. So you need to keep that in mind. This can be indicative of an active infection. So it's a left shift because the way things are in the old days, you just get these written out reports, and it's the same way. You can rearrange them now. But you would have your newest first when you looked on your screen and oldest data points last, and you would see the numbers increasing or shifting to the left. That's where that term comes from. Now, remember, when you give steroids, you do get demargination. When you look in organ systems in your vasculature, you'll have neutrophils hanging on to the side just waiting to be released. But they're not counted in a complete blood count because they're not actually in the blood. But Steroids can lead to demargination where there's a higher number floating. Now, remember when I told you about that, if you have a patient who has a white count of 9K and it's stable, and you start them on steroids, you can expect it to increase by 3 to 5,000 points, but usually it will not get higher than 18,000. So when you see something by that, yes, they're on steroids, you can assume demargination to a certain degree. But if you start trending up above 20,000 platelet or 20,000 in your white count, so you do have a leukocytosis, there's probably something else going on behind there in addition to the demargination. But if you don't I can't spend a lot of time on that. But look up demargination and appreciate what that means when you give someone glucocorticoids. But neutrophils, when it comes to bacteria fighting, this is one of your big dogs, okay? So this is one of the granulocytes. The eosinophils we talked about, you're going to see these more in a parasite infection. Yes, they do cause phagocytosis, but not very effective. It's certainly not the level of a macrophage and a dendritic cell. So keep that in mind. Then basophils, you should be familiar with that. Those are those mast cells. I'm thinking of allergies and leukotrienes, but these are inflammatory and allergic reactions. You'll see these sometimes in type 1 hypersensitivity reactions. If someone's allergic, a basophil is playing a role. So maybe if someone's having a problem, you can look for basophilia, etc. But this is very important to appreciate. Now, we talked about the myeloid cell line, which is what you're active. It's what you're born with. The lymphoid cell line, this is acquired immunity. So this all begins, so we talked about your bone marrow and your cells. This is where, and it begins with the hematopoietic system, but these are slow to respond. And this is going to be over several days. You have to have antibody development secondary to antigen presentation. So this is exposure driven, resulting in memory via your B and your T cells due to antigen presentation. So you're going to have your initial response, but you get exposed to COVID and you get active active immunity. Not passive. We're not giving you antibodies. We're not giving you mother's milk if you're a baby. You're actively developing immune to a specific antigen. And so now you know how vaccines work, right? Or in many cases, how they don't work. Sometimes vaccines aren't, well, I'm not going to say, I think a lot of it has to do with changes in the pathogen, different serotypes, especially with flu. We have to update that every year, but sometimes vaccinations are not lifelong. You have to be boosted or have different vaccines. And you know, the coronavirus vaccine is a big one. They're always changing that because it's always evolving and changing. So something to keep in mind. B cell, this is your humoral immunity, producing antibodies, and these populate in those lymphoid organs. So lymph nodes and spleen, tonsils, these are the ones that are hanging around waiting to do their job, like IgG, you know, CMV virus. If you have a high level of IgM, that may be active infection. If you have a high level of IgG, that tells us you've been infected, but maybe you're no longer infected. So those are antibodies. IgA is a big one. They think patients, that's going to be in excretions, like in your nasal excretions. This may be in there to capture stuff in your nose. And there's thoughts that, is there a correlation between IgA levels and the coronavirus? Do you have enough IgA levels? Those who don't get as sick, do they not get the high inoculum? Because they have high IgA levels in their nose that are knocking it out. I don't know. It's just that's a hypothesis, but it's something to think about. But IgG, IgE, IgM, IgA, these are all important. So T cell mediated immunity, 2 cells, you have your CD4 helper cells. This is very, very important when you talk about CD4 cells. So these are activated major histocompatibility complex 2 antigen presentation. So gosh, macrophages, those dendritic cells, those B cells, these all are antigen presenting cells, and they present the components of the antigen on the molecules of the major histocompatibility complex. And then you have the CD8 cells. These are cytotoxic, so helper T cells and cytotoxic. When you think of CD4, you probably think of HIV. but it's not just HIV. But that's why you see why HIV is so detrimental. In essence, you just broke down a gatekeeper of keeping infection out, and which allows for propagation or replication of, in that case, the human immunodeficiency virus. But your CD4/8, these are going to recognize antigens on those MHC, major histocompatibility complex 1 molecules, again, raising that flag, which is going to cause apoptosis or programmed cell death of those tumor cells, if it's cancer or foreign tissue or virus. Why do I say foreign tissue? Maybe you got a liver transplant, right? Your transplantation patient. So these are very important. When we get to the immunosuppressants, regardless of what they do, you're going to see a lot of discussion around suppression of T cell immunity. So just something to put in the back of your mind for now. Okay. Cell signaling molecules, we've talked about these. There's a lot of them, your interleukins, your interferons, your tumor necrosis factors, and your chemokines. These are just, hey, we got a problem here. And it's like you're bringing attention to something that doesn't belong. Inflammation, remember, this is a protective response. Sometimes we do try to mitigate this for other reasons. Autoimmunity, this is adaptive, right? Our cells are seen as foreign, and we are the antigen. Our own immune system attacks ourselves. So autoimmune disorders, the one that comes to mind initially, rheumatoid arthritis. The second one is type 1 diabetes. It escapes me right now, but we actually have a drug that delays the onset of type 1 diabetes. So I can't believe I just escaped my mind. I was reading about it just the other day to update myself. But then the autoinflammation, this is just a dysregulated pro-inflammatory attack on self. I don't know. I don't want to say, I don't want to misspeak. I'm thinking, I never looked, I wonder if this falls into the line of toxic shock syndrome. I have seen a case of staphylococcal toxic shock syndrome, and I've seen a case of streptococcal toxic shock syndrome, specifically M protein derived. Now, when you talk about toxic shock syndromes, your type 4 method or your type 4 Staph aureus, whether it's MS or MRSA, is irrelevant. But it's usually a type 4, what we used to refer to as community acquired staphylococcal aureus infections, or MRSA is usually what they are. But they're encoded with the PVL. That stands for panting valentine leukocyte. And I don't know. I can tell you this: your T cell response is usually 40 to 50% greater than a normal response. So it is dysregulated, and it's extremely pro-inflammatory. Unfortunately, the 3 I've seen all resulted in death. It's like a total. Think about septic shock times 100. It is horrible to see, and you just dilate out, and it's hard to support the patient. End organ failure. But I don't know if that's what that refers to. But when I think of a dysregulated immune response, I'm certainly thinking of distributive shock and septic shock when it relates to an infectious process. So I may be speaking out of line here, but I think it's giving you a good example. You can get, since we're talking about it, when you think of streptococcus, linezolid and Clinda, don't use Clinda as monotherapy for staph strep, but for streptococcal toxin production, Clinda, we give it the 900 milligram dose, give the big dose, don't give the 3 or 4 or 5, 6, give the 900 milligram IV dose, but it actually binds toxin. So that's a little pearl for you. I don't know if we talked about that in the infectious disease, but it'll bind toxin. So that's something to consider. Maybe you're giving penicillin because you think you have a group B, group A strep. That's fine. But it's okay to give Clinda with it. We're not giving Clinda from an anti-infective perspective because it really doesn't have very good streptococcal coverage, and its staph coverage is it's ebbing and flowing, you could say. Still acceptable, but not what it used to be. But you're giving that to bind toxins. So I think anytime someone comes in with a horrible skin structure infection that's nicely demarcated without purulence, I'm thinking a group A strep, could be a group B strep. I'm going to give probably Rocephin, but I'm going to give it with clindamycin. Now, you could give linezolid by itself. That also binds toxins. So those are a couple of things to appreciate. But I didn't mean to go down that rabbit hole, but I think it's important for you to appreciate and understand the why we do things. Because a lot of times, especially in the pharmacy world, the thought is they're adding Clinda for an anti-infective perspective, and actually it's not. It's to bind toxins, and you need to know that because you don't want to use Clinda necessarily by itself empirically, because it does in many cases. If you have less than 90% sensitivity on your antibiogram, and it's the only drug you have to consider double dual therapy. And Clinda would meet that, so we just don't really use it if it's paraorbital type issues, yeah. But anyway, that's not what we're here to talk about. So let's keep going. So you've seen this or something similar to this. So there's that hematopoietic stem cell down deep in the bone marrow, and you can see the different progenitor cells that it goes to. Your erythroid progenitor cells, those end up becoming either erythrocytes or platelets, right? So red blood cells or platelets. You have your myeloid and then your lymphoid. Those are the ones we talked about. Now, remember, think about myeloid, you're going to start thinking about those basophilic issues, eosinophils, and then the big one for immune system is our neutrophils. But also, it's what develops these monocytes. Remember the monocytes? Mono begins with M, so you know it's a macrophage and a dendritic cell. Macrophage is going to be more of a phagocytic process. Dendritic cells are going to be more efficient in presentation of a antigen within the major histocompatibility complex. And this is going to be happening in the lymph nodes. But then the big one are the lymphoid progenitor cells. Now remember, this is going to be quick. You can get exposed and your white count will jump, pretty quick. So this is happening really, really fast. And you see the problem now when you have cancers where their marrow's been ablated and they have neutropenic fever, none of this is going on. You see the problem. So then you have your common lymphoid, and this is not going on either. So going back to that conversation, you see the problem. But you have your lymphoid, you have your B cells, and then you have your T cells, your killer cells. But there's your T cell and your natural killer cells. So these are going to be the ones, give it 2 or 3 days to kick in. They're going to do their deal. And then your B cells, hopefully your B cells, these are just floating around in the plasma for if you get exposed again, such as your hepatitis B vaccine. If you have a needle stick in the hospital and you have your hepatitis B vaccine, your body's going to recognize that. It's going to nip it in the bud sooner than later, and you don't end up with hepatitis B. The same can be said for your chickenpox, your varicella vaccine, your shingles vaccine. In my case, I have to get Tdaps because I work in the NICU. My Tdap, I don't want to have diphtheria or pertussis running around, right? If I get exposed to it, I'm not going to get sick, and I'm not going to be sneezing out all these replicated strains and spreading it to little babies in the NICU or in the public, whatever it may be. But we don't really give tetanus toxoid anymore. If you get your tetanus shot now, you're pretty much getting Tdap. And even if it's just you don't know, and you might have had a Tdap last week, you don't remember, but your tetanus has been more than 10 years, you're going to get a Tdap. That's if you don't know, you're getting Tdap. That's just what we do. So when we talk about immunization, so here we go. I'm not going to go over all the vaccines, but let's just in general talk about vaccination. So a vaccination that's going to involve the deliberate immunization of otherwise healthy people. Now, I say healthy people because those are immunocompromised. We usually have to give them higher doses or a different regimen, and we don't want to give them live viruses. We want to give them attenuated viruses because we can actually infect them with it. So, but we're going to immunize. We're going to give a healthy person, a patient, whatever we want to call them, with a pathogen, an antigen. Subcomponents, right? Attenuated parts of the coronavirus. You give a part of the spike. Is that what I think? What's that what they call it? The spike thing? Spike protein is what they call it, right? But anyway, when you give a vaccine, that's going to result in the stimulation of your immune memory process that we talked about. In this process, it's induced by those CD4 T cell dependent antigens, right? Which then produce your either short or long-lived dormant clones, I guess. I'm going to say B cells at that point. I think that's what we're going for. I think of T cell as short-term memory. I think of your B lymphocyte as your long-term. But anyway, they're going to rapidly expand after a re-encounter with that antigen, stimulating specific B cells to proliferate to plasma cells. And you saw that on that schematic, that diagram. And those B cells hanging around your long-term memory What are they going to do? They are going to stimulate those specific cytotoxic or killing T cells, those T lymphocytes. So there's really 4 different types of immune responses upon vaccination, and I'm just going to keep it brief because I'm not an expert in this, but you'll have T cell independent, and I'm just going to leave it at that. I'll try to explain it and I'll mess it up, but it's T cell independent 1, you have T cell independent 2, you'll have thymus 1 cell dependent and thymus 2 cell dependent. So it revolves around antigen protein cells that stimulate the different proliferation of different mature cells, B cells specifically in the plasma. There's a lot that goes into it, but just think of TI1 response, think of a TI2 antigens, think of TH1 cell dependent responses, think of TH2 cell dependent responses. These are all things that you can look at and go by. Now, I think I've going to make sure I didn't leave anything off. I don't know how deep I want to go into this because it gets complicated. It really does. So we'll just leave it at that. I don't want to create confusion. So let's start talking about some of the specific vaccinations that are out there. This is very important. And the first one certainly is going to be your human papillomavirus. This came with HPV. Now, actually, this is have a friend who's actually going through this. She has HPV and older than me, but it's concerning because it's created a cancer and it's not good. So, but HPV, that can lead to cervical cancer, vaginal, penile cancer, and anal cancer. You can also get oral cancers from it. But the big ones are type 6 and 11, usually associated with genital warts, but that can be anywhere, not just genitalia. And type 16 and 18, usually cervical cancers. There's a lot of different subtypes of HPV, but these are the big ones. And that's what we're going for with Gardasil. And it's a 2-dose regimen, 6 months between. I don't think this is, double check this. I think they've lowered the ages where you can get it. But this is something, when it was introduced to the market, Merck produced this. Rick Perry was governor at that time, and he tried to put something, and whether you're conservative or you're Democrat, when someone tries to tell you you will do it, I don't believe in that. I don't believe in mass anything. Well, Rick Perry came out and said everybody will get vaccinated with HPV. And people don't like that. And the thing is he owned a bunch of stock in Merck, and it didn't look good for him. I don't think that's the reason he did it. I get why he did it. It was public health. I encourage the HPV vaccine, but I would never tell you, you must get it. But it can save. You never know. Your daughter, your son, whoever their life partner may be, you don't know. Maybe they meet someone when they're 30 that's a saint, but when they were 18, they might not have been a saint. And kind of like it happens. But these cancers can be very aggressive and they can be fatal. So you need to appreciate that. They're curable, they're treatable, but what if I told you we have a vaccine that can prevent cancer? So I encourage it. I encourage it. Your measles, mumps, and rubella, your MMRV vaccines. Again, these are approved for the measles, mumps, and rubella. These are live, okay? Attenuated measles, mumps, and rubella viruses. So you need to keep that in mind when they're live viruses, not just dead antigenic components of a infectious pathogen. You got to appreciate that because this could cause problems in someone who's immunocompromised. The vaccine schedules, though, I'm not going to test you on that. You just need to appreciate that. Influenzas, now we have the high dose, those who are immunocompromised. So someone with congestive heart failure, diabetes, COPD, asthma, I would recommend the high dose, or anyone over 65 for sure. It just has a higher antigen component to it to try to elicit a more profound immune response. Most are now quadrivalent. I think they all are. They will have 2 influenza A strains and 2 influenza B strains. But remember, the initial process is an 8 when you have that and then subsequent T cell recruitment. That's why it takes so long. You haven't been exposed to it. If you have an immune, that's why when you get the vaccine, you may still get sick, but you're getting some response initially instead of your line of feeling bad like that. Maybe you get like that. Now, you may go on for the full 7 days, but you don't get as sick. So the whole thought of if you've had the flu shot, you can't get the flu is not necessarily true, but it can certainly mitigate it. Again, I am a fan of everybody getting the flu shot. I like to tell people wait till the flu season starts to heat up because I do think that the immunity, if you get your shot too early, can ebb and flow, wax and wane. So just something to keep in mind. Your varicella, this is a big one. So the varicella zoster virus, this is your chicken pox. Then you have your herpes zoster, which this is your subsequent reactivation, or what we refer to as shingles. You have the Virovax, which is an alive attenuated varicella zoster virus, and I won't go into the schedules. You all will need to know this though when you get in practice, and then your Zostavex to prevent herpes. Usually age 50 and older. I have not had mine. I will tell you, you get the 2-shot series. I think the first dose goes fine. From what people tell me, the second dose goes horrible. So no good. Now, one thing that I would keep in mind, it's not that shingles itself can be horrible. It's going to follow those nerve roots, you know that. So it's usually only going to affect one half the body and follow the nerve root. It can be pretty profound and go multiple routes. And you certainly want to get on antivirals, acyclovir or valacyclovir as soon as possible within the first 48 hours of an eruption if you really want to have an effect on it. But the reason they say it, it's not necessarily, well, you have shingles, it can hurt. It can be painfully painful. But the problem is you can have post-herpetic neuralgia. And if you've had the vaccine, maybe if you do have an outbreak, it's short-lived and you really don't know what's there. And the big thing is, does it help prevent, if you do get exposed, does it help prevent that post-herpetic neuralgia? And the answer is yes, it does. Now, do we have an immune globulin for herpes zoster or varicella zoster? We do have it, but we only give it to immunocompromised patients or pregnant women. That's when it can be catastrophic. So if you're an otherwise healthy person and you have the shingles, even if you have an active outbreak, you can go ahead and start getting vaccine at that moment. But just know, if you go trying to get the immune globulin, it's not going to happen. That's going to be pregnant women or immunocompromised. In this case, when I say immunocompromised, I'm not necessarily talking about the diabetic. A comorbidity that leads to immunocompromised diabetes, CHF, COPD, asthma. It's going to be someone who is truly immunocompromised and taking medication. So just something to keep in mind. Here's your diphtheria, tetanus, and pertussis. There's 3 main differences. You have your big DTaP and your Tdap. So the big DT is a combination vaccine. This is to provide immunity. This is not a booster. When you see the little one like this is your booster. This is what I get every year. But your first shot will probably be the DTaP with diphtheria, tetanus, and acellular pertussis. When you get the other ones, you want to get your full tetanus toxoid. That's the one that runs out. You lose your immunity after 10 years. But you just want a booster of your diphtheria and your acellular pertussis. So your DT, your big DT, that's a combination that's going to give you immunity against diphtheria, tetanus, and pertussis. And then the small Tdap, that's used to boost your immunity against those same 3 pathogens. So your Tdap, in essence, is going to contain lower doses of those antigens. And that's because you should already have some sort of immune response. We just want to wake it up. We just want to boost your immunity. We don't need to build up immunity. We just want to wake it up and make sure, hey, you still breathing down there? You go from there. I'm not going to go into when these are approved. I will ask you, please go to the CDC website and at least read through the vaccination recommendations from birth all the way into the elderly, and just appreciate what all is expected. That's something I haven't put it to memory. I do know when would I want to recommend a flu vaccine or a pneumococcal vaccine, an HPV vaccine, the adult vaccines. I know what I would recommend there. The childhood vaccines, there's so many combined combinations now. It's gotten a lot easier, but those can be pretty detailed schedules. And that's why you have your well baby checks. They're going to keep you online. Okay, we'll see you in 3 months. And when you show up, they'll be able to give the vaccines that are required. The meningococcal meningitis, no doubt those who are going to live in a communal area, kids going off to college. I did have a friend whose son was at Odessa College back in '95. He got a call on a Friday night, actually rented a plane to get there because he couldn't get there in time. But his son ended up with Neisseria meningitidis meningitis, and he passed away in 24 hours. Even if you survive the disseminated and intravascular coagulation and all the things that go on, even if you survive meningococcal meningitis, you're probably going to be missing some limbs and other things because of the stenosis or the thrombosis that goes on. And it's not good. So there's a vaccine for that. And as we send our kids off to college, they usually get this. But I think this is part of the standard protocol now. But anytime I think of meningococcal meningitis, I think of Butch and his son Jesse, and I think of my kids living in a dorm. Lindsay lives in an apartment now, but my daughter Ashley, soon to be in a dorm, and I'm pretty sure she has this. But you can bet your last penny I'm going to make sure that she has her meningococcal meningitis vaccine. Anyway, you see your 5 most common serotypes. It's A, B, C, W, Y, and there's different. You have the meningococcal conjugate or the Menactra or Menveo. Which one do we carry in the hospitals? It's usually which one we can get the best contract price. When we see these in the hospital, again, remember, this is encapsulated. So this is one of those ones, if we have splenectomy, we're giving. So why would we have this in the hospital? That's why. I don't see Bexsero and Trememba much because they only cover the B. These are the two that I'm familiar with, Menactra and Menveo. And that's because they cover all of those 5 serotypes, the ABC, YW. And how do I remember those? ABC, then YW. So I can't give you a fancy mnemonic. It's kind of like, I don't know, it's kind of like warfarin and the vitamin K dependent clotting factors. I just know that 2, 7, 9, and 10. I just know 2 plus 5 is 7. So 2 and 7 and 1 minus 10 is 9. That makes no sense, but it works for me. I just A, B, C, and then I go to Y, Y, W. So I know that did not make a bit of sense, but you do what you got to do to remember this kind of stuff, and that's how I get there. So anyway, very, very important. And yes, you will see this in the hospital, and specifically patients who've had a traumatic splenectomy, or they're just asplenic, whatever it may be, or they're about to have a splenectomy. We will give it now. We can give it before splenectomy. Don't quote me on this. You need to look it up. I think if you've had a splenectomy, you need to wait a couple of weeks before you give the vaccines. I don't think it's immediately after, but that's something that can be easily Googled and looked at and go from there. Okay. So polio vaccine, I think I got bamboozled when we went to Africa because I was told I had to get boosted. And so I got another polio shot. But I remember as a kid getting a polio oral drops. But what I got for my travel medicine to Africa was a shot. But anyway, this is you all probably are not familiar with polio. I am. Anybody that's my age in their 50s probably had a family member that at some degree or some level got affected by polio. I think if you all familiar with Mitch McConnell, he's a senator, not sure what state's from, but I think he has a post-polio type syndrome. I think he had polio, but you would have people in these iron lungs. But this is a testament to how vaccines can benefit the whole populace. if they're done right. But anyway, I'm not going to go into the recommendations. You all can read through this. I don't know what all they recommend. I will tell you that there are different strains of those. I think they're enteroviruses that I think enterovirus 69 might have been polio, but we're starting to see some derivatives of that that are causing some of the paralysis that we would see in polio. But I had an uncle that had a great uncle, might have been a great uncle actually, but I remember his story. But most of us in my age and older knew someone or a family member that had polio. It wouldn't be someone in our generation. We were very fortunate to have a vaccine when we were kiddos. I was born in 70, but not everybody had that. So, but anyway, look at your CDC guide for your immunizations and go by. So we're not going to go through everything, but that kind of gives you an idea about vaccines. Now, here's where we get into the discussion on immunosuppressants. So yeah, this is oh God, this is how I want to explain this. This is how I want to frame this. You may not work in transplant medicine, but you may. It depends which route you go. Those of you who go into nephrology in big centers, you will. You may work with a transplant surgeon, but they're not necessarily going to be the ones taking care of it after the fact. They're going to do the surgery, but then a specialist in cardiac or lung or liver or kidney transplant is probably going to pick up, an internist with subspecialty is going to pick up the management. And immunosuppressives, for the most part, all have very narrow therapeutic indexes. So, but if you get too low, you can have a graft rejection and lose the graft, kidney, whatever it may be. If you get too high, you can have systemic toxicities that can lead to problems. So we're going to talk about these. I'm not an expert in this. I have not dealt with this at a deeper level. I did do a rotation in a bone marrow transplant clinic, and that was in the 90s. And we have far better antifungals. Ours was more supportive, but because they were ablated initially and they were at an extreme risk of infection. So it was like Fort Knox. You weren't going in unless you needed to be, kind of like COVID. You weren't going in unless you were needed because we were trying to keep the junk out. But we do see these even in my work at United Regional, wherever it's been. We have patients come in with immunosuppressants. And one thing that we're cognitive of as pharmacists, what we're really looking for is the potential for drug interactions, because these, no doubt, have a high risk of drug interactions. And then you got to look like cyclosporin and nephrotoxicity. You got to watch for that. And we'll talk about levels, but your levels will be appreciably higher initially after a graft, but over time you can decrease doses, but you have to understand when do you make those changes. And I'm not going to go into that kind of detail, but I do want to at least introduce you to immunosuppressives. So the big one we're doing, and again, I put up here, there are times when the immune system actions are harmful and unwanted. And this would be when autoimmune diseases, diabetes, right, or rheumatoid arthritis. Remember, in those diseases or psoriatic arthritis, we use those DMARDs, those disease modifying rheumatoid drugs. But our focus is going to be transplants and grafts. So immunosuppression is actually the desired outcome. And you're going to see, back when we talked about this, a lot of this is going to revolve around T cell suppression with different mechanisms. So I want to make sure that you all appreciate that. So the immunosuppressants, we're going to talk about different classes. One we've talked about are the corticosteroids, and this is going to be methylprednisolone and prednisolone. You know them. I don't need to go hydrocortisone. Yes, we will use these chronically for immunosuppression, but you have to watch for glaucoma, you have to watch for cataracts, you have to watch for osteoporosis, you have to watch for steroid-induced diabetes, you have to watch for adrenal suppression, and if a patient becomes stressed, you need to make sure they get a stress dose of a corticosteroid. We talked about all that, so we're not going to hash that out again in detail. The antimetabolites, this is very important. These inhibit chemical reactions that are necessary for the formation of what? Lymphocytes And specifically, when I think about this, I'm thinking of T cells. That's where a lot of the damage comes from. So, and then again, your calcium inhibitors. When I think of this, I think of cyclosporin. And you'll see a lot of them like sirolimus or tacrolimus. Uh, Tacrolimus is one of those, but sirolimus not necessarily. There's one called rapamycin, rapamune, but we're going to talk about those. But you can see three main groups. You have your mTOR receptor inhibitors. This is going to be, there's your sirolimus and your virolimus. These are going, again, look at it, suppress immunity by changing the way T cells. Have you noticed a trend? Everything is T cell. T cell. Selective T cell co-stimulation blockers, your belatacept, binds to immune system cells that present antigens to the T cells, preventing their what? Activation and proliferation. So you'll see a lot of what we're doing are T lymphocytes. That's what we're mitigating. So it's something that you have to keep in mind. So antibody preparations, these are going to be your ATGs, your antithymocyte globulins. There's horse, there's rabbit. We use rabbit. Muromab, CD3, and then your balsiliximab, that's your interleukin-2 receptor antagonist. But again, these are going to suppress the immune system by depleting resources. So where do we start? Our ATG. This is a good one. I want to make sure there's nothing that we needed to. We'll get into, well, I don't really want to get into therapeutic index. Just know when we talk about these drugs, and we'll mention it, but there's going to be dose-limiting toxicities for the maintenance of all these immunosuppressant agents. So that's why a lot of times you will see a combination of immunosuppressants with different mechanisms of action. And the reason we do this is they can be used in lower individual doses, and we get an increase in efficacy, but maybe not an increase in side effects. I think that makes sense, right? So anyway, the agents, where are we going to start? Our ATGs. So what do we talk about this? This is an interesting, so ATG, when you see this, you can also think of the word thymoglobulin. These are polyclonal rabbit. There's horse and there's rabbit. We don't do horse. Horse has a lot of antigenic potential, so I don't even know if they're still out there. But anyway, these are derived antibodies against human T cells. But the horse is the same. It's an anti-lymphocyte globulin, but like ATG, it's not commonly used. So let's talk about this one. And these, go to your textbook and read what they have, especially like infusion-related effects, so on and so forth. But ATG, or that thymoglobulin, what we use is it's a polyclonal, and it's a rabbit-derived antibody against human T cells. There's that human T cell, and we use it for both the prevention, hear what I'm about to say, the prevention and treatment of acute rejection and organ transplantation. If a patient is having an acute rejection, we will use ATG then in there. But its mode of action, it's going to be selective depletion of T cells by complement-dependent lysis. And there's that word complement again, but we don't really know the exact mechanism necessarily. But it's T cells. Everything we do is T cells. So I don't want to go into I don't know if it's T cell clearance from the circulation, modulation of T cell activation, is it cytotoxic activities? I don't know, but there's a lot that goes on. In which T cells, I don't think we have it in there. It could be CD2, 3, 4. The list goes on and on. There's a bunch of CD4 cells, HLAs, HLA class 1 heavy chains. I could start rattling off a lot of stuff, but a lot of that goes into it. The main thing we need to be mostly focused on is those adverse reactions that can occur with ATG. So anyway, we use it for the prevention and treatment of acute rejection and organ transplantation, and then given at transplant or reserved for treatment of steroid-resistant acute rejection. So all this is important. So the adverse effects, the cytokine release syndrome, most of you are familiar with Actemra or teclistamab in the use of COVID. They think it's increased an exaggerated cytokine response. It's a drug that's used for cytokine release syndrome. But when you have cytokine release syndrome, that can lead to your fevers and your chills, your pain, headache, abdominal pain, diarrhea, nausea. So that's something to keep in mind. The leukopenia, the thrombocytopenia that can happen. Now, the anaphylaxis, and keep in mind, when it comes to ATG, the rabbit and the horse is more profound, but we use rabbit, can occur up to 3 days post-infusion, and it's an immunosuppressive, so it can increase your risk of infection. So the patient is going to be in isolation, but we do pre-medicate this with steroids and antihistamines. So it's just something to keep in mind. Before we leave ATG, the takeaway is the cytokine release syndrome. That I need you to do. And then you can also, those post-transplant lymphoproliferative disorders that we just mentioned. So just keep that in mind. Just making sure there's nothing that I didn't miss. I don't know. I probably missed something, but anyway, as far as the horse-derived antibody against human T cells that's used in the treatment of acute organ rejection as well, but we don't use when you see the horse, it'll say ALG, the rabbit is ATG. So anti-lymphocyte globulin, we don't use that as much. It has a more profound cytokine release syndrome in the short term. So that's not, and actually those lymphoproliferative disorders as well can be more profound. So it's just something to keep in mind and something you need to appreciate. So I think we're good with ATG. So we'll move on to the next one is basiliximab. This is a chimeric monoclonal antibody. So this binds to CD25. I refer to these as interleukin-2 receptor antagonist. It binds to the CD25, but this is also the interleukin-2 receptor and inhibits what? Interleukin-2 mediated. Wait a minute. There's that word. Everything revolves around inhibiting T cells. So, and this would be induction, and it's well tolerated. So we use this for prophylaxis, not for rejection. That's where the ATG comes in, and it's very important that you appreciate this. And if you looked at how there's another drug, it's daclizumab is another one that can be used against interleukin-2. That's going to be like daclizumab. That's going to be more along the lines of cytokine release syndrome that we talked about. But when you think of ATG, the first one we talked about, think of rejection and prophylaxis maintaining. But with basiliximab, I want you to think of prophylaxis of acute rejection in renal transplantation in combination with cyclosporin, that's a calcium urine inhibitor, and corticosteroids. This is not for the treatment of rejection. It does not deplete. It does not deplete T cells. It just stops the proliferation. So, but this is going to be, gosh, it's a mouse antibody. So you have all these different, we talked about a rabbit, a horse. So a lot of these come against that. But again, I mainly want you to think of it as an interleukin-2 receptor antagonist. But these agents, they have a pretty profound effect on the immune system. So they're used for short-term therapy only. So when you see these, they're commonly prescribed in the initial post-transplantation period to prevent early or acute rejection, but we don't use them for the treatment. These are all for the prevention, but these are used early on. And I believe these are dropped. These may even be something you see just in the hospital. This isn't something you go home on. So, and it's working on those progenitor cells, T cell progenitor cells. So just something to keep in mind, but you're just not going to have T cell proliferation. Trying to think, I'm pretty sure, again, I'm not an expert in this. If you're in a transplant center, these weren't out when I was working in a transplant center as a student. It was just a rotation that I did at University of Arkansas for Medical Sciences. They actually did some stuff there. None of the stuff I did in Oklahoma City. Well, they might do organ transplants in Oklahoma City. I was at a hospital called Mercy up in the Northwest Corridor, and it was more of a 300-bed hospital. We did not do. We had organ transplant patients come through there for other issues, but really back then all we had was cyclosporin and sirolimus. Anyway, but the next one, our calcium urine inhibitors. These would be, to me, these are the ones I'm most familiar with. You see them. Well, you used to see them quite often. We probably have better alternatives now, but these are your calcineurin inhibitors. Okay, so I like to call them immunophilin binders, if you will, but cyclosporin and tacrolimus. So both of these are calcineurin inhibitors. And solid organ transplants for cyclosporin, you'll see this abbreviated sometimes as CYA. So if you ever see that, we don't like abbreviations in pharmacy, but sometimes you'll see that back when it was written. Now everything's electronic, so it's not. But in renal liver disease, you'll see this in psoriasis, rheumatoid arthritis, and some other. There's cyclosporin eye drops out there. This is big. The metabolism is through the cytochrome P453A4. So this is one where you got to watch for numerous drug interactions. Where it's an inhibitor of this enzyme, you get too high levels and toxicities. It's an inducer. You end up, the patient shows up, oh, I have acute organ rejection, and their level is now 50 instead of 300. But you can see the whole list of side effects for both of these. Hypertension, I mean, the list goes hyperlipidemias. A lot of metabolic issues go on. The hyperkalemia is going to be associated with nephrotoxicity. Hirsutism, the gingival hyperplasia, no doubt. The hand tremor and headache, this is something that I have seen in a tacrolimus patient, someone I knew that actually had this hand tremor, almost like a Parkinson's patient, if you look at it that way. But when we talk about these, though, again, they have different mechanisms, but it's always going to revolve around those T helper cells. So, but when you look at the common target for cyclosporin and tacrolimus, it's going to be that calcineurin. And after binding to that cyclophilin, you might have heard me refer to these as cyclophilin inhibitors, but calcineurin inhibitors. But after binding to that cyclophilin, the cyclosporin or the tacrolimus, it interacts with calcineurin. And that inhibits a catalytic domain. And when you do that, you get what they call dysphosphorylation of transcription factors. That's prevented. And when do you see this? Well, it's usually going to be on those activated T lymphocytes. So there you go. And tacrolimus is going to work in the same way. But at the end of the day, what you're looking at is T cell disruption. You're gonna disrupt it. So I hope that makes sense, but let's just stick to, you heard me use the term cyclophilin, but inhibits calcineurin, and that's going to be an inhibition of T helper cells, okay? And interleukin-2 plays a big one in that. But you see interferon gamma. I could go on and on and on with this list. Cause interleukin-2, tumor necrosis factor alpha, interleukin or interferon gamma, and others, but they're reversibly inhibited, blah, 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 blah. But you must watch for its strict therapeutic drug monitoring is required. So you must watch for drug-drug interactions. Now, the big thing when we talk about these drugs are the adverse effects, and it's for both agents, but the big one is nephrotoxicity. Let me say that again, nephrotoxicity. But cyclosporin and tacrolimus, the why? Well, why does it cause nephrotoxicity? But cyclosporin and tac decrease renal blood flow, and which in turn can cause hypertension. And is all this starting to add up on those side effects up there, the why? And that can lead to fluid retention, and then, well, the hyperkalemia, and then progressive renal dysfunction. But when you talk about the renal dysfunction you see, it can be a functional toxicity, which is reversible, that improves when the drug is discontinued or the dose is lowered. But you can also have a chronic, and this is important, a chronic nephrotoxicity, and that's going to be characterized by interstitial fibrosis. So just keep that in mind. In a hyalinosis, there's a lot of stuff that goes on in there, and that's why you can see those degradation type hyaline cyst or whatever they call them in a UA. I think that's the term. The hyalinosis is the term, but I just on a UA you can see cast. I think that's the word I was looking for. So anyway, we do routine serum drug concentration monitoring when we give calcineurin inhibitors, both of these. And then I mentioned both of them are metabolized by the cytochrome P453A4 system. So yeah, there's many drugs that can interfere with the metabolism. So some of your common ones, just off the top of my head, ketoconazole, not as much, because we don't see it. It will, but we don't use it as much, if ever. Erythromycin, we have better options, but fluconazole is one we see a lot. Cardizem, diltiazem, that's one we see a lot, especially when they come in the hospital. Corticosteroids, that's one we see a lot. And then also remember those drugs that could decrease blood levels. These are the ones that make me worry, is when we decrease levels. And those are going to be those inducers. And when I say cytochrome P450 inducers, I hope you think rifampin right off the top of your head. But I'm thinking phenobarbital, phenytoin, carbamazepine. Now, good thing we have better drugs like heparin and things like that now, but still people are on them. But we tend to avoid them in patients who have these issues. So just keep that in mind, please, 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 please. Okay, and then I mentioned the functional. Okay, so we're good. So belatacept, this is a co-stimulation blockade for specifically for renal, but approved for kidney transplant and plant transplantation in combination with basiliximab, mycophenolate mofetil. These are two good drugs, and corticosteroids. So these are a substitute for cyclosporin or tacrolimus to avoid those detrimental long-term nephrotoxic effects and those CV complications you might see. I'm just to say metabolic complications, because I mean, look at that. If that's not a metabolic derangement, I don't know what is, but that's why we use it. It's used in that. But if a patient contraindicated in patients who are seronegative to Epstein-Barr virus, and I used to know the why to that, and I can't remember. I apologize for that. Look it up and see why, and go from there. But I don't think really I haven't I'm trying to think of a time that I've seen belatacept, and I don't think I have. So some of these, it makes you wonder, are these things even still on the market? But I don't know. I don't think it is. We'll move on. Anyway, so we don't confuse these mTOR inhibitors. This is the sirolimus and the virolimus, the rapamune. I'm on a rapamune because I got a new kidney. We wrote a little song to remember it, a little jingle to remember what it was. But this is don't get these confused because it ends with limus. Don't get it confused with tacrolimus is a calcineurin inhibitor. So anyway, this is where the FKB12 comes in. So, but sirolimus, that's going to be your prototypical drug, and just know it was formerly known as rapamycin. And these block those activating signals that are delivered by growth factors. And this is going to be exemplified again by interleukin-2. Do you see a commonality there? But it's exemplified by that interleukin-2. That's what's going on. In the end, we're going to have T cell proliferation suppression. And again, T cell. If you notice, everything revolves around the T cell, but it'll bind, and you see that FKBP. So that stands for your FK binding protein. The sirolimus interacts with those mammalian target of rapamycin. So mTOR, mammalian target of rapamycin. That's what that stands for. We are inhibiting that. And that's why it used to be called rapamycin. So because of the mammalian target of rapamycin. So what you'll get phosphorylation of the mTOR, and it leads to a dissociation of what they call eukaryocyte initiation factor 4F, which is, I thought I had it on there, but it's not. But that's what it comes. And that's a DNA inhibiting the translation or the coding of messenger RNA. I'm getting myself confused, but it's for key proteins that are required for progression through the different phases of the cell cycle. It's arresting the cell cycle. That's the end game. And when you arrest the cell cycle, you're going to inhibit the proliferation of lymphocytes, and specifically those T lymphocytes. So just keep that in mind. We use it. It's approved, and you can see there it's adjunctive at best, right? But that's where we will use it. And for prevention of acute renal allograft rejection is where that's going to come from. But you can get, even though we use it to prevent some metabolic derangements at times, you get dyslipidemias from that. And specifically, your total cholesterol and your triglycerides tend to go up. But it's something to keep in mind. Most of these patients will need a lipid-lowering drug because this is an accepted side effect of these drugs. So, but you can see their indications there. But that's what the mTOR stands for, mammalian target of rapamycin. But we don't call rapamune rapamycin. We used to call it that, but it's sirolimus and Afinitor. So administrations oral. Oh, this is just specific for Tacro and Cyro. You all can read through there on your own. Just remember though that Tacro is a calcineurin inhibitor, and This is a mammalian target of rapamycin. Just think rapamune, right? Uh, Inhibitor. The end game, though, T cell proliferation is snuffed out. That's what we're doing. Snuffed out. Put a big X by it. So keep that in mind. Clinical pearls. We talked about this is more of a tacrolimus right here. The edema is directly related to the hypertension. And yeah, you get fibrosis, you get the interstitial fibrosis, it's going to be irreversible. So let's just keep that in mind. And then azathioprine, gosh, we use this. It's not necessarily for transplant, but you could put a drug called mycophenolate in here too. But this class of drugs, poorly understood mechanisms, but this class of drugs, it's used for chronic immunosuppression. Two major anti-metabolites within these groups, and I don't know, I don't want to call them I guess we could call them anti-metabolites, right? That's what I always referred to them as, but sometimes I like to find a name for these that fit. But anyway, your two drugs are going to be azathioprine and then mycophenolate mofetil, but there's two different forms of that. I'm just drawing a blank. One of them has, the only difference is one of them is dissociated in the gut. It's more of an extended release. It has less GI side effects. Mycophenolate can rough your gut up, so it's just something along with some bone marrow suppression and things like that. But these have a wide range of indications. But anyway, they prevent lymphocyte proliferation. And anti-metabolites, the reason they're called that is because it's inhibition of a purine-based synthesis. And in the end game, it results in decreased production of building blocks for DNA and RNA. So azathioprine, if you remember, we haven't had our oncology lecture, so you don't remember this, but azathioprine is actually metabolized into what we call 6-mercaptopurine. You'll see it abbreviated as 6MP sometimes, but this gets converted into, it's like a thioinosine, I think, a monophosphate. We call it TMP or TIMP. I think that's what it stands for. I think I said, fact check me, but TIMP, I do know that. But the molecule, that's going to inhibit key enzymes in that de novo pathway of purine synthesis. So by default, when you're messing with the adenosine monophosphate or guanosine monophosphates, those are the two bigs, AMP and GIMP, or AMP and GMP as I call them. When you do that, you're going to get an anti-metabolite. So that's why we have that. And I hope I didn't do injustice. We call this TIMP, though. Thiocynic acid, I call it TIMP. But it's incorporated into lymphocytes, and again, suppresses T cells and has anti-inflammatory activity. Everything suppresses T cells, T cells, T cells. But what do we use it for? We use it for transplant rejection prophylaxis, but rheumatoid arthritis, Crohn's, myasthenia gravis, miscellaneous immune diseases. Azathioprine is used for a lot. Mycophenolate, no. We'll talk about mycophenolate. I think it's in the one, but with azathioprine, you have to appreciate it has substantial bone marrow suppressive issues, and it can actually increase your risk of cancers, of malignancy. So those are going to be your major toxicities. But when I think of mycophenolate, which they may have its own slide, I think of GI side effects. Now, it used to be, it's mycophenolate mofetil is the one that is slowly disintegrating, I think, and then the mycophenolic acid is the one that's just instant. The only difference between the one is one has less GI side effects when it comes to the mycophenolate. But let me look. Make sure I didn't miss anything. We talked about 6-mercaptopurine. Why it's an anti-metabolite. And then the adverse effects. Don't forget, though, the bone marrow suppression, and that's what's going to lead to these infections. And then the TMP deficiency. You probably need to do some pharmacogenetic testing if you're going to go this route. I'm not sure if it's required. Remember, I don't work in this world, but your TPMT and your new T15, you may need to appreciate or check for that. And then may test. I don't know if you test or not, but again, we don't work with this, but you're going to be monitoring a CBC every 2 to 4 weeks after initiation, and you're going to watch for infection. Nausea and vomiting are common. This is going to be, I see this with the mycophenolate more than the others, but the mycophenolate mofetil seems to have tampered that down some when it comes to mycophenolate. So keep that in mind. And there it is right there, the CellCept and Myfortic. Myfortic is the new brand that has the delayed release with less GI side effects. But again, we're talking about AMP and GIMP. So again, the guanosine nucleosides, which I just mentioned, and those are required for those T and B cell proliferation. So pretty much the same. And you can see here all the indications for these. CellCept. I got to plug my computer in real quick. It's telling me low battery. So let me make the switcherooski. There we go. So these are very hard lectures to give, by the way, because these drugs, they're just so. But when we do see them, I'll typically get my drug book out and I'll make sure I look up everything I can on them, because I don't want to be the reason someone has a organ rejection. So, but the mycophenolate products, whether it's CellCept, I would recommend Myfortic over CellCept. Less GI side effects. These are safer and more effective than azathioprine for transplant patients. For azathioprine, you're going to see this more in your non-transplant immunosuppressive disease, rheumatoids, Crohn's, myasthenias, etc. And let's see, and you can see with Myfortic, these are going to be your main uses. You could see it in lupus, myasthenia gravis, but these are going to be your solid organ transplantation is what you're going to see. Now, these are just prophylaxis. It's not for rescue. The big one for rescue is going to be high-dose steroids, high-dose corticosteroids, and your ATG, your thymoglobulin, the rabbit thymoglobulin. Not the horse stuff. Not that. So make sure, I think, so Myfortic, that's a takeaway to a pearl. That's the one we would use to decrease, not prevent, but you have a decrease in the risk of GI side effects, and it can be bad. And there's the nausea, vomiting, diarrhea. It is immunosuppressive. You do have risk for drug interactions, so those are all things you need to keep in mind. Do not interchange mycophenolate sodium and mycophenolate mofetil. It's not a milligram for milligram, but if you saw someone on mycophenolate sodium, you would want to look into, okay, can I go to mofetil? Or while they're in the hospital, if they need changes made, reach out to their transplant doctor at their transplant center and talk to them on the phone. In the hospital, if you come in on mycophenolate mofetil, that's what you're going to get. We stock both for that very reason. It's the same with cyclosporin. There's different cyclosporin brands. There's Sandimmune and there's another one. We don't substitute those for one and the other because they're not one and the same. But again, the nausea and vomiting, diarrhea are common. You take with food. But remember, the mycophenolate mofetil has less. That's the Myfortic, has less. So now we get to, and we've talked about these, so we're not going to go into these in great detail because we've talked about them, but these are going to be your tumor necrosis factor alpha inhibitors. The T is more, don't think interferon, that's a T. There's not interferon gamma, but not alpha. But tumor necrosis factor alpha inhibitors, you can see the macrophage. You have tumor necrosis factor. You have your endothelial cells, activated endothelial cells, leukocyte adhesion. Same thing over here, synovial fibroblasts, interleukin 8, interleukin 6, interleukin 1. You can see the immune process that's going on. We are intervening right here. This is where we're working. And so in essence, you're stopping all this inflammatory process. So it binds to tumor necrosis factor alpha to reduce inflammation in various inflammatory states. Now, tumor necrosis factor alpha, you see it over there, induces interleukins. It induces leukocyte migration and activation. These are all of what we call acute phase reactants. So very, very important. We're stuffing. There's your T cell production, propagation. So infliximab or Remicade is probably the prototypical. We don't use that as much. You can auto-induce autoimmune responses to the drug, but Enbrel is a big one. This is one we see quite a bit. Psoriatic arthritis, Humira for Crohn's disease. Those who aren't responding to Humira sometimes will go to Simponi or Cimzia. But these are all drugs that we dispense quite often in our infusion center. Humira, not so much because it's sub-Q. These two are sub-Q and you can get it home. But these right here, these three right here, Cimzia, Simponi, and Remicade, yes, for sure. But these are very, very good drugs. Now, these are not necessarily used for, these are immunosuppression, but we're not using these for organ transplantation, prevention of rejection. These are going to be more your Crohn's disease, your ulcerative colitis that's more advanced, your ankylosing spondylitis. If you're not familiar with that, look it up. That's an extremely painful phenomenon. Psoriatic arthritis, plaque psoriasis, and there's many more that goes to this. These are disease-modifying agents, though. These are agents that actually slow the progression of the disease, not just treat the symptoms. The list can go on and on, though, what we use these for. You just need to appreciate that their mechanism, by inhibiting tumor necrosis factor alpha, look at all the inflammatory pathways that are mitigated or blocked. And you can see while they work, but you're thinking, okay, these must increase your risk of infection. And I would say true story. But they're IV, some are some Q or sub Q, it's not all. But, it takes a couple of weeks, but all of these, you're going to have a risk of infection. You do want to rule out TB. All of them have a risk of an hypersensitivity reaction and infusion reaction for those that are IV. You're going to have a risk of cancer because they are suppressing your immune system, and then you can get marrow suppression as well. So, but they're tolerable. People spend their lifetime on these, and you might see again. I always think of Phil Mickelson talking about psoriatic arthritis and taking his Embrel. So, clinical pearls, you got to get tested for TB. You want to watch for infection, edema with associated heart failure, or heart failure causing edema. Which came first, the chicken or the egg? And then usually the first dose will be administered in the provider's office or in an infusion center. Those that are IV will continue to be given in an infusion center. But some of these are injectables, non-IV injectables that you can give at home. So that's really nice. Now, when we talk about these are B lymphocyte, we see like rituximab, you'll see this like in CHOP-R for different cancers, but these bind CD20 cells on the B lymphocyte. So if someone had a T-cell lymphoma, could you use one of these drugs? And you're saying, oh, sure. No, because these are B cell inhibiting. So that's one thing you'd have to remember. That could be a little trick question on a test. But rituximab is going to be your big one. And these, in essence, by binding to the B lymphocyte, we're going to induce apoptosis and go from there. You can see the mechanism. There's your T cells right there, NK killer cells. There's your complement mediator. There they are. C3, C4, C6 is CH. Those are part of your complement, but you can see what the B cell is doing. And when you bind that CD20, you can see where there's rituximab, and you can put all those. You're inhibiting that direct process. So just something to keep in mind. Where do we use these? Chronic and lymphocytic leukemias and lymphomas, where we see them big time, and especially with the CHOP-R combination, are Hodgkin's and non-Hodgkin's lymphomas, but RA, myasthenia gravis, and other miscellaneous autoimmune and inflammatory conditions. We've discussed these, so I'm not going to go in a lot of details. So there's you always got to watch for PML because that's going to be life-threatening for sure. But TB, mucocutaneous reactions are big. Tumor lysis syndrome, we'll talk about that when we get in oncology. This is going to be more along the lines when you start your initial treatment for chronic lymphocytic leukemia, lymphomas, and Hodgkin's disease. The reason being is you're going to have a high cell count, and you're going to start lysing those cancer cells very, very quick, and they're going to dump those metabolic processes or trash into your blood, such as uric acid. You're going to get up 12, 13, 14, 15. Well, that's going to increase your risk of uric acid nephropathy. That can lead to renal failure. That can lead to a rhabdomyolytic process. The whole thing can be a cascade of events. Life-threatening hyperkalemia. So we preemptively give hydration and uric acid drugs and other medications because we're aware that can happen. You always got to watch for those mucocutaneous reactions and then hepatitis B reaction. We're checking for these. So just things to keep in mind. We usually, with rituximab, we are going to pre-med for sure. There's different protocols. We used to give this over an extended time period, but we now have a fast infusion protocol, which when you give it with steroids, your diphenhydramine and your acetaminophen, you can mitigate those infusion reactions. Again, we do test for TB, and it's given in an infusion center. Your corticosteroids, we've talked about this in previous lectures. Again, if you look over here and you see the end game of steroids, and there's all your different types. Remember, your The one that mimics cortisol the most is hydrocortisone from a glucocorticoid. The one from a mineralocorticoid, remember fludrocortisone or Florinef for the sodium water retention from an adrenal perspective. But decreases inflammation and inflammatory and decreases inflammation by suppressing leukocyte migration and capillary permeability. Many other effects leading to adverse effects. So you can see here what all it does. So yes, if you know this right here, you get it. Corticosteroids are great. That's why they make us feel so good when we take them. When we have a backache or whatever, they're very good, but they come with a whole list of problems. But we do give steroids when we talk about immunosuppression for the transplant patient. It's common, and it's usually given as prednisone, and of course prednisone is converted, as you all know, in the body to the biologically active compound, and that's prednisolone. But corticosteroids, when you look at this whole process over here, when you look at it from an immunosuppressive effect or organ transplant, let me phrase it that way, corticosteroids inhibit interleukin-1 and interleukin-6 production, and this is the APCs. Remember, APC stands for antigen-presenting cells. So a number of events associated with the T cell activation and the interleukin-2 production are inhibited. So they're going to interfere with the action of interleukin-2 and probably interleukin receptor activity as well on T cells. Again, there's your magic word, T cells, but you're going to get inhibition, though, of helper and suppressor T cell and suppressed T cell function. That's what's going to happen. And do you get interleukin 3, 4, 6? Do you get interferon activity inhibition? You do. You get some of that, and you can see it on there. I don't think it's as profound as interleukin 1 and 6. I really think that's when you think about it, that's when you have the biggest response. But I don't think when it comes to B cells, and we can look at that, and I've had this question, because could you use this in a B cell lymphoma? And the answer is I don't think you can. And I've meant to, and I think this picture tells me 1,000 words, because I've had this discovered before. Can they inhibit early B cell proliferation? I think, yeah, probably, but it's going to have minimal effect on those activated B cells. So this is going to be a T cell phenomenon for sure. And but yeah, I don't know. We're talking about immunosuppression. That gets into cancer. Let's just keep it for organ rejection. That's what we're looking at it for. But you all know, we talked about this in detail. Many well-known adverse effects of corticosteroids. It can be the hypertension, the hyperlipidemia. It can upset the stomach with ulcers. The corticosteroid-induced diabetes, the osteoporosis. It can lead to obesity, the humps, moon face, the cataracts, increased susceptibility to infection. What else can I say, right? But when transplant patients are on your prednisone, that's what they're going to be on. It's usually a very low dose, and it's for life of the transplant. It could be 5 milligrams of prednisone, not 15, 20, 30, 40. It's usually going to be a lower dose, but they're going to have an underlying level of hypothalamus pituitary adrenal axis suppression. So if they did become sick or they were admitted to the hospital, they may require a couple of days of stress dose steroids. So that's just something you need to keep in mind. I don't know. We've gotten so much better with transplant medicine. Used to, it was the standard. Everybody would be on 5 milligrams of prednisone, it seemed like. But I think we do better now. I just don't, this isn't something I work on, but I can tell you, though, if you do have acute rejection, we will give very high doses of corticosteroids. That I do know. So just something to keep in mind. And overall, though, when you talk about, we're talking about transplant rejection. Remember, transplant preventing rejection, it's going to be a low dose. If they have acute rejection, you'll see that thymoglobulin, the ATG, the rabbit, not the horse, remember. And you'll see that given at a high dose. But your big one in your career, though, is going to be more COPD and asthma. That's where you're going to see a lot of steroid use. So just something to keep in mind. Multiple sclerosis, again, we'll do like 1,000 milligram dose. But we're focusing on immunosuppression, so we'll sit there. I need to look up. I don't think the effects. I know CHOP-R has Rituxan. I know Rituxan is B cell. So I'm trying to think. I need to look that up. I really don't think it's activity, though. I don't think it has a lot of B cell activity. I think activated B cells, it's a negative. I'm pretty sure about that. But I think of those progenitors, I think it may have an effect. Some of these differentiate the same pathways. So yeah, it may be. That's something that's not pertinent to this discussion, but I think when you start thinking like that, I think that's what's challenging. I will say this: when you're working and you're looking at something like this here, and a thought comes up like mine, as soon as we're done with this lecture, I'm going to look it up, and that's how you have continuous quality improvement of your own database and yourself. Because I'm going to look at the effects of activated B cell uh, inhibition by corticosteroids. That's going to be my search when I go into the mesh. Okay, so gosh, there we talked about these: the Cushing adrenal, the suppression, Cushing infections, the hypertension, the glucose. These are all we've talked about all these. The psychiatric disturbance, I've seen people, I always tell people if you get put on a Medro dose pack, now is the time to paint the house because you're going to have a lot of energy. But we have gone through these in detail, and you know that PO, IV, IM, inhaled, they're ICS for asthma, rectal, topical, they're all there. Rectal for hemorrhoids, rectal for ulcerative colitis, topical for that little erythema, that little rash you have from getting in the evergreen bushes. Inhaled for your asthma. Remember, ICSs are the drug of choice for the most part for asthma to keep you in not having asthma attacks, keep your asthma under control. So, clinical pearls, we talked about adrenal suppression. When you have greater than 20 milligrams of prednisone equivalent for 1 to 2 weeks, you will get adrenal suppression. When patients are in this state, they will need stress dose replacement. When they're in this state, we taper very slowly. So keep that in mind. Gosh, this is all stuff. If you have questions on any of this, we went through this all in the spring. But you need to know all this. Now, when we talk about immunosuppression and rejection, low dose possible, short as possible, it's usually going to be lifelong if they're using it. This is very important, though, to appreciate. We taper them short-term use so you don't have a re-exacerbation of like COPD. So we'll give you this high dose and slowly taper down. It's not a tapering. I'll tell you what works good. If you look at the gold standard, they say do 40 milligrams of prednisone orally for 3 days and you're done. The reason they'll do the taper in the hospital is slowly taper them off. It's not because of adrenal suppression. It's they want to make sure they don't have a re-flare of their exacerbation. So it can go both ways. You get them, you have the dose is up here, and their disease is right here. Then as they taper, the disease kind of starts to come back up. So they want to take it nice and slow. That's why they do that instead of just like, So keep that in mind when you talk about, but that's the definition, 20 milligrams. I go by 7 days. If you've been on a prednisone equivalent of 20 milligrams or more for 7 days, I usually recommend a taper, not a slow taper. It can be pretty quick in most cases. But if you get out to 2 weeks for whatever reason, heaven forbid, I don't know why, yeah, you probably need to do a slower taper because you're going to have some adrenal axis. That HPA, you're going to have some hypothalamus, pituitary adrenal suppression. And you remember the ACTH, the corticotropin releasing hormone, the ACTH, if you don't remember all those pathways when we talked about the pituitary gland, the master gland, right, making all that cool stuff, you need to go back and review it. So that ends the immune system. Woo. That's a tough one. So we will discard, and I will stop my share. That's me. I'll let you look at me just so you know I'm there. I turned the video off because it throws a picture of me over there. Anyway, yes, my background has changed because I had to plug my computer in. Okay. Week 6, lecture 2. That's what this is. Week 6, lecture 2. The next quiz is not until after the mission trip that's coming up. So anyway, I have experience in what I just talked about when it comes to organ rejection from a 4-week rotation in school and what has tricked. Well, I got some of it. I did temporarily work on a heart transplant team, but the program got eliminated from the hospital I was working at. But that was more from a surgical ICU perspective. I did not work in the graft host rejection world of it. So anyway, I'm just not schooled in that. And it's probably something I wish I knew more about. It's fascinating, but they have doctors and providers and PAs and pharmacists that's what they do. And they're very good at it. And I'm grateful they're there. Anyway, my URH pharmacist friends or anyone else watching this, Feel free to reach out if you have questions. Anyway, otherwise, whatever day it is you're on, I hope your day's great.